An atom is the smallest division of all matter visible to the human eye. Animate, inanimate, all constitute a structured basic building block. Structured is the word you would want to ponder upon because everything existing has some form of structural integrity. For example, a collection of atoms leads to the formation of one of the toughest known objects on the planet, a diamond, and its foundation, an atomic structure. Similarly, the human skeleton is the epitome of structural foundation. The immaculate intrinsic and harmonious network of vessels, minerals, plus so much more is truly a work of pure fascination. What is more amazing is how well the skeleton handles stress and pressure despite enduring a ton of wear and tear, and continues to develop alongside the human body. What we want to emphasize here is the structure of anything is of the utmost importance, and even the tiniest of changes can lead to an altered, undesirable response. Which leads us to the question, what are these responses? How is the change possible in a system with such intricacies? So, without any further delays, let us all get into the defect of structure of one of the toughest body tissues, the bone, which is fibrous dysplasia. Fibrous dysplasia is a disease process in which the normal medullary bone and cortices are replaced by an excessive proliferation of cellular fibrous connective tissue intermixed with irregular bony trabeculae. As you can see, histopathologically, normal bone have trabeculae that are oriented in response to stress and strains placed on the bone, whereas trabeculae in fibrous dysplasia are oriented randomly and have increased amount of fibrous tissue. The resultant fibro-osseous bone is more elastic and structurally weaker than the original bone. This irregular tissue can weaken the affected bone and cause it to deform or fracture. Fibrous dysplasia is non-hereditary. It occurs due to an acquired genetic mutation that begins in the embryo. The time of embryonic mutation determines the type of fibrous dysplasia. Polyostotic fibrous dysplasia is the result if it occurs in the multicellular embryo. We see monostotic fibrous dysplasia if it occurs during mid-embryonic development, and craniofacial fibrous dysplasia if it occurs during the late embryonic development. There is a mutation in GNAS1 gene which encodes for G protein, which is involved in the production of cyclic adenosine monophosphate in many tissues involved in endocrine function, melanocyte activity, and maturation of osteoblasts. So now that we know GNAS1 gene has been altered, an abnormal amount of cyclic AMP is produced, which causes an excess of the enzyme tyrosinase to be produced, which causes hyperfunction of the endocrine organs, high melanin production, and incomplete differentiation of osteoblasts. As we have seen, a gene mutation can have an impact on an embryo at different stages of development. A large number of daughter cells will be affected if the mutation happens early in the multicellular embryo, which will result in polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia? What's that? Typically, only a few bones or as much as 75% of the skeletal system can be affected by this type of fibrous dysplasia. The long bones, ribs, and skull are typically affected. Bone pain, usually a mild to moderate dull ache, facial asymmetry, and spontaneous fractures, especially of the extremities, are the initial clinical findings in most of the patients. Remember how cyclic AMP leads to hyperfunction of the endocrine organs and melanin production? This condition is known as McCune-Albright syndrome, which has a triad of symptoms: polyostotic fibrous dysplasia, cutaneous melanocytic pigmentations, and endocrine abnormalities. Café au lait spots, which are melanotic pigmentations, are often very irregular and resemble the coastline of Maine, which never crosses the midline, as opposed to neurofibromatosis, which has the look of the coastline of California with smooth borders and a crossing midline. Another type called Jaffe-Lichtenstein's describes polyostotic fibrous dysplasia with cutaneous melanotic pigmentations in the absence of endocrine abnormalities. Masobrod syndrome is characterized by fibrous dysplasia in combination with multiple soft tissue myxomas. This shows a higher risk of malignant transformation among the three syndromes we've discussed so far. The potential malignancies could be osteosarcoma, fibrosarcoma, chondrosarcoma, and malignant fibrohistiocytoma in the decreasing order of frequency. Radiographically, the radiolucent lesion is surrounded by a thick sclerotic border. This is the classic sign of fibrous dysplasia called the Rind sign. The characteristic shepherd's crook or hockey stick deformity results from the curvature of the femoral neck and proximal shaft. The normal femoral neck shaft angle is 160 degrees at birth and 125 degrees in the adult life, which becomes less than 120 degrees in fibrous dysplasia, which is called Coxa vara. Involvement of the upper femur frequently results in leg length discrepancy, the bowing of long bones in a way that the patient is unable to approximate, leaving a big gap between the knees, can also be observed. So, this was when the mutation occurred earlier in the embryo. But what if the same genetic defect occurs around the 6th week of embryonic development, when most of the histodifferentiation and cell migration has already happened? In that case, the daughter cells will be localized to one region and thus may produce monostotic or solitary type of fibrous dysplasia, which affects multiple sites of the single bone. Although mandibular lesions are truly monostotic, maxillary lesions frequently involve nearby bones such as zygoma, sphenoid, and occipital, and therefore these are not monostotic and should instead be referred to as craniofacial fibrous dysplasia. They show the typical leonine appearance known as leontiasis ossea. In contrast to polyostotic fibrous dysplasia, which affects children under the age of 10, monostotic fibrous dysplasia affects a slightly older age group. It is often discovered as an incidental finding in dental diagnostic images made for other purposes. Patients with jaw involvement may first complain of unilateral facial swelling. Later, there is pain, swelling increases in size, and there is deformity of the affected jaw. Let's look at some radiographic findings now. Here, mature lesions show evidence of radiopaque spicules in the radiolucencies, giving the ground glass appearance or orange peel appearance. Other than that, there are other appearances like fingerprint-like pattern and cotton wool pattern that can be seen. The periphery of the radiolucency is ill-defined and appears to blend into the surrounding normal bone. In the mandible, this pattern of enlargement affects the bone more evenly along its length, and when the growth occurs in the lower border near the inferior alveolar canal, it may displace the canal in a superior direction. Fibrous dysplasia arising in the maxilla can shift the cortical borders of the maxillary sinus. It can also affect the adjacent teeth, in which case the lamina dura may vanish. The PDL space may become smaller, teeth may shift, or it may obstruct normal tooth eruption. Hypercementosis or some root resorption may sometimes take place. Advancement in the presentation of the lesions shows a new type of fibrous dysplasia called the maxillofacial dysplasia. The craniofacial bones affected by fibrous dysplasia involves extensive defect of facial bones and the bones of the skull. Mandible, being an anatomically freestanding osseous unit, could be said to be affected by monostotic behavior, but historical records do not go in favor of it, as several earlier diagnosed cases of monostotic fibrous dysplasia of mandible were later diagnosed either as polyostotic fibrous dysplasia or ossifying fibroma. Thus, the term maxillofacial fibrous dysplasia could be said to be a more fitting designation for patients. The histopathological appearances of fibrous dysplasia can vary according to the relative maturity of the lesion or area of the lesion being examined. Microscopically, fibrous dysplasia consists of well-vascularized cellular fibrous connective tissue containing irregular trabeculae of immature bone, sometimes having a Chinese letter pattern, which is also called the alphabet soup pattern. The bone in some jaw lesions or part of lesions may show evidence of osteoclastic activity or be rimmed by osteoblasts, a feature suggesting an active phase of the disease. In contrast, areas of moth-eaten spicules devoid of osteoblastic rimming, which can be seen in some lesions, may represent a burnout phase. The lesional bone blending directly with the normal bone are some other histologic features of this disorder. Globular calcifications may be seen in jaw lesions of fibrous dysplasia. Laboratory findings may not be diagnostic. The serum alkaline phosphatase level may occasionally be elevated in fibrous dysplasia. Premature secretion of pituitary follicle stimulating hormone and a moderately elevated basal metabolic rate have also been reported. There are many variables that affect the treatment. The only available treatment for monostotic fibrous dysplasia is aesthetic surgery. Complete excision is the goal in order to improve facial appearance and function. Additionally, optic canal decompression surgery may be required to avoid blindness. In addition, vitamin D and bisphosphonate medications may be helpful in treating bone pain, enhancing function, and reducing the risk of fracture in patients for whom surgery is contraindicated. A multidisciplinary approach is necessary for the treatment of various bone abnormalities throughout the body and endocrine dysfunction in polyostotic fibrous dysplasia. Though fibrous dysplasia causes facial bone asymmetry, one of the upsides of this pathology is that it is fully treatable along with restoration of aesthetics and function.